Hello, my name is Samantha Navas, and I will be discussing a case study with you today on a disease process commonly discussed in advanced physiology and pathophysiology. A 40-year-old male patient comes to the emergency department with a chief complaint of having shortness of breath while walking around his home, and also stating that he often feels his heart racing and is feeling very tired even after rest. The presenting signs and symptoms seen in the patient are shortness of breath, tachycardia, 1+ edema of the bilateral lower extremities, and obvious fatigue. While there are multiple differential diagnoses this patient may have, listed on this slide are possibilities of common diagnoses seen based on the patient's chief complaint. Of the highest priority, the first diagnosis to be considered is pulmonary embolism. This is chosen as the highest life-threatening possibility due to the shortness of breath with activity and tachycardia. Commonly seen with PEs is a rapid onset of shortness of breath. This should be ruled out as it can be a life-threatening disease process. The next diagnosis that could be considered is acute kidney injury. This is chosen due to the lower extremity edema noted on the assessment and shortness of breath, as he may be retaining fluid through a kidney injury. The last three diagnoses that could be considered are pneumonia, COPD, and asthma. All are chosen due to the respiratory issues and fatigue noted by the patient. These are common diseases that should be ruled out based on the patient's chief complaint and signs and symptoms noted on assessment. While these are all great considerations, the overall diagnosis that my patient has today is congestive heart failure. Congestive heart failure can be masked by many other diseases. Those commonly could be listed in this slide. The pathophysiology of congestive heart failure, according to Malik, is that heart failure is a complex disease that results from a functional or structural disorder impairing the ventricular filling or ejection of blood in the systemic circulation. Congestive heart failure can be grouped into three causes, one being impairment in the heart's contractility, 2, chronic increase in afterload or restrictions in ventricular relaxation and filling, and lastly, chronic increase in tissue or blood flow demands beyond the range of normal cardiac output. The pathophysiology can be described as so: a decrease in cardiac output, an increase in afterload, and an increase in myocardial contractility. Malik goes on to describe that a decrease in cardiac output stimulates the neuroendocrine system, causing vasoconstriction, leading to the increased afterload. An increase in the afterload will cause pressure overload in the heart and change the ventricular function of the heart. There is also an increase in cyclic adenosine monophosphate that causes an increase in calcium. The increase in calcium will also increase myocardial contractility. The increase in myocardial contractility leads to an increase in myocardial oxygen demand. This leads to myocardial cell death, as the heart cannot keep up with the oxygen demands. The decrease in cardiac output will then turn on the RAS system, creating an increase in salt and water retention. This process will continue to repeat, leading to the overall diagnosis of congestive heart failure. This process of heart failure causes an increased amount of stress and workload overall on the heart. We must remember that the heart is a muscle, and increasing the workload and contractility of the heart will weaken the muscle and can cause many other comorbidities that will follow along in the process of heart failure. The overall pathophysiology for heart failure remains the same, but the clinical manifestations can alter throughout the lifespan. Although it is not as common, children can also have heart failure. The common manifestations in children and adolescents can be commonly missed as they mimic many other diseases, as stated before in the slides previous. Most children with heart failure present with fatigue, labored breathing, abdominal pain, chest pain, nausea and vomiting, and an increase in nighttime urination may be seen as well. As for adults, the clinical manifestations are few and may also be mistaken for other diseases. Adults present with dyspnea, peripheral edema, and orthopnea. There are many different ways to identify and diagnose a patient with the disease process of heart failure. Laboratory and diagnostic studies can be done to indicate heart failure in a patient. Laboratory studies that may indicate heart failure include a complete blood count, also known as a CBC, a basic metabolic panel, also known as a BMP, with renal function, liver function testing, troponin levels, and a B-type natriuretic peptide test. A CBC should be done to show if there are any signs of anemia, as that can worsen heart failure. A BMP with renal function should be done as chronic kidney disease can be a contributing factor or a comorbidity of heart failure. The liver function test should be done as abnormalities in the liver function are associated with severe heart disease. A troponin level should be completed as it can detect underlying ischemia. And lastly, a BMP should be done as it can help show when the heart is exposed to significant myocardial stretching. Although the BMP is a highly sensitive test, it is not specific to heart failure alone. Diagnostic studies that can be done to indicate and diagnose CHF are an electrocardiogram, a chest x-ray, an echocardiogram, and a stress test. An EKG can be done to evaluate for the etiology or precipitating factors of heart failure. A chest x-ray can be done to show cardiomegaly, central vascular congestion, and interstitial edema that may be present in heart failure. An echocardiogram is done to evaluate for pleural effusions, inferior vena cava size, and respirophasic variability and cardiac contractility. The echo will help to evaluate the patient's ejection fraction, which is one determining factor of progression of heart failure. Lastly, as exercise intolerance and reduction in aerobic activity and aerobic capacity increase in someone who have heart failure, a stress test can be done to evaluate and measure the patient's aerobic capacity or cardiorespiratory fitness. This in turn will assess blood and oxygen flow to the heart. The management and treatment of congestive heart failure is key to prolonging life expectancy and overall living to a close to normal lifestyle. There are both pharmacological and non-pharmacological treatments for heart failure. Pharmacological or medications commonly used for heart failure include angiotensin-converting enzyme inhibitors, also known as ACE inhibitors, angiotensin receptor blockers, also known as ARBs, angiotensin receptor neprilysin inhibitors, also known as ARNIs, beta blockers, diuretics, mineralocorticoid receptor antagonists, or MRAs, ivabradine, sodium glucose transporter 2 inhibitors. Some non-pharmacological management includes eating a heart-healthy diet, or a DASH diet, which consists of lots of fruits, vegetables, whole grains, low-fat dairy products, poultry, fish, nuts, and legumes. Tracking your fluid intake is important as heart failure patients are known to retain fluids. Quit and avoid smoking, maintain a good exercise habit, monitor weight to make sure there is not an increase in fluid, as gaining 2 to 3 pounds in 24 hours or 5 pounds in a week should alert the patient to see a doctor. Avoid or limit alcohol intake, and lastly, monitor blood pressure to control hypertension. There are many cultural and socio-cultural considerations for those with heart failure. Some major cultural considerations that should be taken into thought would be areas with unhealthy diet practices. The main diet issue for heart failure would be sodium intake. It was found that both northern China and Japan have the highest rate of sodium intake in their diet, while majority of Western cultures, including the United States, have a lot of processed foods that contain high amounts of sodium. This in turn will play a role in the rate of obesity. Having a high BMI can cause hypertension, which in turn causes stress and myocardial stretch on the heart, which can cause heart failure. The United States has the 12th highest obesity rate out of all the countries in the world. Another cultural consideration to take into account is environments of high stress. Living in a place of constant movement, always being on the go, the pressure to work and succeed can cause the sympathetic nervous system to constantly be stimulated, in turn causing your body to have vasoconstriction, altering one's baroreceptor reflex, causing a higher level of blood pressure, leading to chronic heart failure. Some social cultural considerations to apply for heart failure include disparities and vulnerable populations. Hospitalization is more common in African American males than any other race, and heart failure risk factors are seen more in Hispanic populations. It was shown that social determinants of health played a role in longer hospital stays in those with heart failure. The social determinants to take into account are areas of lower income, lower levels of education, housing instability, health disparities, and being born outside of the United States. All of these issues can affect outcomes of congestive heart failure. Heart failure is staged by both A through D standards and by classes 1 through 4. Prognosis of heart failure will depend on what stage A through D or class 1 through 4 of heart failure the patient is in. Stage A is someone at risk for heart failure. Stage B is someone who's considered pre-heart failure. Stage C is someone with symptomatic heart failure. And stage D is someone with advanced heart failure. The classes are again 1 through 4 and are based on the patient's symptoms. Patient with class 1 has no limitation in physical activity and has ordinary physical activity. A patient with class 2 has slight limitation of physical activity, and ordinary physical activity may result in fatigue, palpitations, shortness of breath, or chest pain. And someone with class 3, less than ordinary activity causes fatigue, palpitations, shortness of breath, or chest pain. Whereas class 4, the symptoms of heart failure are seen at rest, and any physical activity causes further discomfort. Jones has a study that shows that international studies have shown that when CHF is managed in the community outpatient setting, that at 1 year, there's an 80 to 90% survival rate. At 5 years, there's a 50 to 60% survival rate, and at 10 years, there's a 27.4% survival rate. Jones goes on to state that more recently, there has been no change or very modest improvements in survival. The prognosis of heart failure will steadily get worse as the disease progresses. Therefore, it is of major importance that the patient treats the disease and is educated appropriately. The overall outcome of the disease is based on treatment, management, and lifestyle modifications that the patient makes. Life expectancy will depend on how heart failure is managed and other comorbidities that the patient may have. When diagnosing someone with heart failure, it is very important that we teach the patient how to manage this disease. Podvorka states that increasing self-care and self-management of the disease improves the quality of life, reduces rehospitalization, and minimizes eventual complications. As we stated throughout this PowerPoint, the heart failure patient must comply with these education guidelines. The patient must watch their weight and do daily to weekly weights, reduce sodium intake and follow a heart-healthy diet, stay active and exercise, quit smoking, decrease or quit alcohol intake, manage their stress, and take medications as prescribed. They must go to all follow-up visits, stay up to date on laboratory testing. The most important education to give a patient is to make sure that they pay close attention to changes in breathing patterns, increased swelling of lower extremities, frequent coughing, and a sudden weight gain of 2 to 3 pounds in 24 hours or 5 pounds in a week. All of the signs listed in the last part of this slide are all signs that should trigger the patient to see a physician as soon as possible. The last slide includes all references noted in this presentation and are here for you to look up if you'd like to see the studies done on congestive heart failure.